Okay, so the idea now is to talk about the pneumothorax in the radiographic side, maybe. So let's start with what are the causes of pneumothorax. We have the iatrogenic, meaning we did something and it caused pneumothorax. For example, we did percutaneous biopsy and we punched the lung by doing a biopsy, and this caused a pneumothorax. A bowel trauma or ventilator, for example, I don't know, endotracheal intubation that has too much of positive pressure caused pneumothorax. So those are the iatrogenic causes. We have the trauma, we have cystic lung disease, we have parenchymal necrosis, and other things. And when I'm talking about trauma, for example, laceration or a rupture for some reason, when we're talking about cystic lung disease, for example, bulla and bleb can cause it, and it can even be in healthy young men. So you need to know that, and if there is a young man with a pneumothorax, it may be this thing, and there is recurrence. So if the patient had bulla or bulb, especially if it ruptured and caused pneumothorax, so it may happen again. Another cause of cystic lung disease that can cause pneumothorax is emphysema, asthma, the obstructive lung disease, PCP, honeycombing. And when we're talking about honeycombing, it's essentially an end stage of the interstitial lung diseases. Now, there is also the disease lymphangioliomyomatosis, which can have a rate of 75% of pneumothorax, but I'm not going to talk about it. Eosinophilic granuloma is another cause. It's around 20% of patients with eosinophilic granuloma can have pneumothorax, so it's quite high. So if I summarize it, cystic lung disease that can cause pneumothorax are the bulla, bleb, the emphysema, the obstructive lung disease like emphysema, asthma, PCP, honeycombing, which is the end stage of interstitial lung disease, lymphangiomyomatosis, and eosinophilic granuloma. Those are the cystic lung disease that can cause pneumothorax. Now, when I'm talking about parenchymal, when we're talking about the parenchymal necrosis, there are three main causes of parenchymal necrosis that can cause pneumothorax. The first one are it's a category. So the first category is things like lung abscess, necrotic pneumonia, septic emboli, tuberculosis, fungal disease, and you see that there are mainly infections related. And the other one is not infection related, it's cavitation neoplasma or osteogenic sarcoma. So this is the tumors part. And the third category in the parenchymal necrosis is the radiation necrosis. So those are the parenchymal necrosis causes for pneumothorax. So patient after radiation, patient with sarcoma, patient with lung abscess, those can cause a pneumothorax. Now, there is a other category, let's call it, that is quite interesting, which is called catamenial, which is recurrent pneumothorax during menstruation, and it's associated of endometriosis that went to the pleura. Think of it, endometriosis, the endometrium of the uterus that went not to the ovaries, not to the bladder, not to the GI tract, but went until the pleura. It can cause recurrent pneumothorax during the time this tissue from the uterus bleeds, namely during menstruation. It's a very interesting one, catamenia. Now, What are the radiographic signs of pneumothorax? Now, the appearance is air in the pleura when, remember that air in the pleura meaning there is something that is radiolucent in the pleura. So when you're looking at the lungs, you see the lungs that are a little bit radio-opaque if you want, or less radiolucent than the air that around it. And then when there is a pneumothorax, you see an area which is much more radiolucent. This is the radiographic sign of pneumothorax. And then there is a pneumothorax in the external side and inner side, that the lung that is pushed by the pneumothorax if you want, and there is a line between them, white line of the visceral pleura. Now in order to detect it, you can look at the lateral decubitus, upper expiration film, and CT. Now CT is the most sensitive one, and in the lateral decubitus you want to put the patient in that way that the suspected site for the pneumothorax in the lateral decubitus is up. If you think of edema, pleural effusion, or something with fluids, so put the problematic side down, so you see the fluid that goes down. But in pneumothorax, when you think about air, in the lateral decubitus, put the problematic side up. Fluid, put it down. Air, put it up. Upright expiration film can also help. And of course, when you want to be more sensitive, do a CT. Now, sometimes we want to evaluate the size of the pneumothorax. Yes, consider it, for example, if we want a conservative treatment for small pneumothorax that is not traumatic, we need to evaluate its size and think if it's small enough that we can try conservative treatment with oxygen, without chest tube or things like this. So we need to evaluate the size of the pneumothorax to know if it's small and what percentage the pneumothorax is. For this, we have the average distance of the pneumothorax. And using the average distance, we can evaluate the percentage of the pneumothorax, which is the average distance in centimeters times 10. This is the percentage of pneumothorax. For example, if we have average distance for pneumothorax of 1 centimeter, we will multiply it by 10 and we'll get 10% of pneumothorax. If we have AD, average distance in centimeter, of 4 centimeter, it corresponds to 40% pneumothorax. Now, how do I decide what is the average distance AD, so I can translate it by multiplying by 10 to percentage of pneumothorax? The idea is that the average distance is based on 3 distances that we can evaluate, A, B, and C. We sum them all up, divide by 3, and this is the average distance. As it is called, it's average, so we sum them all up and average them. 3 ingredients, divide by 3. So A, B, C. A, I want to see if there is no. Okay, so A, you can think of it as, look at the lung, take the distance between the apex, go down vertically until you hit the lung. All this area with pneumothorax, with air only, between the pleura or between the chest in the apex, if you want the parietal pleura, to the visceral pleura if you want, the area in which the air accumulated between the apex and the lung in the vertical way, this is A. Now, go from A downward around the middle way from A to the lowest point in the lung, in the middle, if this is the lung. So if you go just half the way and you measure the horizontal distance between the chest wall and the lung, all this area with air, this distance is the B value. Now, if you go more downward, almost to the costophrenic angle, almost to there, this is again horizontal area between the chest wall and the lung. This distance with air is the C distance. Again, you evaluate B, apex vertically to the lung, B, midway horizontally, C, almost the lowest point horizontally in centimeters, A, B, C, sum them all up, divide by 3, and you get the average distance. Multiply the average distance by 10, you get the percentage of pneumothorax you have. Okay, that was the how we can evaluate the size in percentage of pneumothorax. Now, let's move to talk about tension pneumothorax. Yes, tension pneumothorax, we have pneumothorax, but when there is a tension, the pneumothorax causes compression of the mediastinal organs, the heart, the mediastinum, the esophagus, the trachea, and push them with a force. So it's tension pneumothorax. There is in tension pneumothorax a valve effect in which the air accumulates in the chest, in the thoracic cavity. And there is increased pressure that, when you look at it, shifts the mediastinum, and eventually it will compress the vascular structure in the mediastinum, and of course reduce the inferior vena cava and superior vena cava, return of blood to the heart, and reduce preload. Can cause cardiogenic shock, for example, because it compress the veins, compress the heart, and it can compress the preload, and therefore tension pneumothorax can cause shock. So in tension pneumothorax, the treatment is emergency chest tube placement, usually between the 4th and 5th ribs, above the 5th, so you won't damage the vein below the rib, vein, artery, and vein below the ribs. So usually before 4 and 5 ribs in the axillary line or anterior axillary line, there is the chest tube above the 5th rib, so you won't damage the vein. Be careful not to puncture the liver in the right side and the spleen in the left side. He will bleed heavily if you do, and it is quite dangerous. Okay, so pneumothorax and tension pneumothorax. Tension pneumothorax, there is a displacement of the mediastinum, compression of the veins can cause shock. There is a valve mechanism. In pneumothorax, there is just collapsed lung and air in the pleural cavity. Now, in tension pneumothorax, what we can also see in the radiograph, we can see overexpanded lung because the air accumulates so much. The diaphragm, when you look at it, instead of a dome shaped, it can be depressed diaphragm. It can compress the diaphragm because there is high pressure there. And of course, you want to see the shifting of the mediastinal tissues, for example, the heart, to the contralateral side because the high pressure. Now, when we are talking about percutaneous chest tube placement, as I said before, fourth to fifth ribs usually, there is some who say that you should go more superiorly. The reason is, again, that if you go too much low, you can puncture in the right side the liver, in the left the spleen. So sometimes the recommendation is go up, go between the second and fourth ribs in mid clavicular. Oh, this is not for what I wanted to say. No, this is what I want to say. Let's forget about it. Just what I said, between the fourth and fifth ribs in the anterior axillary line, there above the fifth rib, so you won't puncture the vein under, inferiorly to the rib. Be aware from the liver and the spleen. And if you are not sure, maybe a hint or a tip will be go up if you're not sure, because it's better to go up than go down, in sense of not damaging the liver and the spleen. Now, after you put your 12 or 16 French drainage catheter for chest tube compression for pneumothorax, you can remove it. If there is no pneumothorax, after you clamp the catheter for 24 hours, and if 24 hours the catheter is clamped and there is no pneumothorax, you can get it out. There are some who said that you need to enter it in the largest area of pneumothorax defined by the CT, but I gave you something that is more general. I think it's better. Okay, so usually symptomatic pneumothorax, especially traumatic, gets chest tube. If there is very small non-traumatic one, you can consider in some cases to do a conservative treatment with oxygen and observation. And if the pneumothorax is small enough and the patient is stable and not too much symptomatic, you can consider it. But many times, especially if the pneumothorax is symptomatic, especially if it's traumatic, you will go with chest tube. Now, that's what I wanted to say about pneumothorax. Thank you very much. If there are any mistakes or correction, please tell me. I wish I said most of the important things about it. If I made any mistakes, I'm sorry. Thank you very much, and that's about pneumothorax, and that's it.